All right. Thanks for everyone coming.
Thank you. Okay. So we're gonna be discussing today again the EBD placement indication, troubleshooting the EBD, zeroing the EBD. Uh, Maybe we're gonna start by saying like the two main functions of an EBD. That would be
Drainage of CSF and then monitoring of ICP.
okay. And what would be the main reasons or causes where you want to drain the CSF from a patient?
Acute hydrocephalus.
It would be, yeah, it would be acute hydrocephalus. It would be either like the patient is producing an excess of CSF that is very, very rare. Like kind of like if you have a plexus tumor or something like that, and they're overproducing CSF, that's very few cases. Then it's like when the patient, it is not absorbing CSF appropriately, and that could be because there's an obstruction of the CSF pathway. That it could be blood, tumor, inflammation, anything that kind of obstructs the circuit of the CSF, or it could be blood or any sort of leptomeningeal disease that also interferes with the ability of the arachnoid granulations to reabsorb that CSF, right? So in any case, there's a buildup of CSF that the patient cannot drain appropriately. So we help them by placing an external ventricular drain. And then where do you place the EVD, and do you want to go through the quick steps, or how do you place an EVD?
Sure. So usually if it's a standard patient, we always go for the right side so we can avoid the left dominant hemisphere. We go for a frontal catheter for most people. So a right frontal EVD, we go through Coker's point, which is about 10.5 centimeters back from the nasion and about 3.5 lateral or the ventricular line.
2.5 for 3.
2.5 for 3. I've been going for 3 recently to keep my hole more medial. And then you're aiming for the medial canthus and the ipsilateral tragus, and that'll hopefully get you to where you want the tip of this catheter to go, which is in the foramen magnum, or not foramen magnum, foramen of Monroe. That'd be really bad. Foramen of Monroe, the same side that you're going in, and that's where the pressure is most equilibrated, and hopefully you can get the best sense of the ICP, and then also prevent this from clotting off, because then if you do, you have to revise it or place a new catheter, which is not ideal. So those are the steps. Generally how it's done, we prep sterilely, we make an incision, we retract, we drill a hole, we will tunnel a trocar, because this gets tunneled under the skin. So it's like you have this part actually in the head, this part goes under the skin, and then the end of it actually comes out behind where the incision line is. So we'll tunnel it, then secure it, and connect it to this bag. And you close skin normally. So then when we connect it to this bag, something important is that it's all primed with fluid, because you see all this tubing here and all the way up into here. If that's filled with air, then it can airlock. And so that's a common cause of this not draining. And obviously you guys need to know that, because they're going to call us all the time when it's not draining. So if you go and you see that there's a bunch of air in this tube, that's a huge reason why. So we do a good job to prime it first, then connect here to the part that's actually in the patient. That's basically how you get it all set up.
Cool. So once you once you see, like if you get a patient that it has a EVD placed, what are the things once you see the patient for the first time, when you come to bedside to assess the patient, what are the things that you're going to be looking at?
Just before we get to that, just in the steps, obviously, once you drill the hole, you got to puncture the dura and then put the catheter in. You skip those. Yeah. And then, usually we're going to kind of like 6.5 centimeters at the outer table of the skull, sometimes 7, depending on how much shift there is, or 7.5. There's a lot of shift. You might need to go a little bit deeper. And everybody ends up, when they're placing it, kind of having their own biases as to like if they miss, how they miss. And so like I used to name for the ASN, because I was always whenever I use the medial canthus, I tended to be too lateral. So I kind of would use the Nasion and stuff. But generally speaking, most places in the skull, if you aim perpendicular to the skull, if you're at a point that like you can hit the ventricle at, then if you're perpendicular to the surface of the skull, then you'll hit the ventricle. So what are some other entry points? You know,
You can do Fraser's,
Mhm.
and just go occipitally.
So the Indian, and then you go
What is it like?
6 and 4.
Just kind of forward.
So 6 up and 4 over.
4 over.
Yeah.
And then I don't know. I guess you just aim perpendicularly.
You kind of
from
aim
there.
a little bit for the
Yeah,
Nasion
for Nasion.
and that one too. Yeah.
Okay.
Yeah.
Yeah, just don't want to go
And
inferior.
and it's pretty horizontal.
Helmet.
Yeah. You're pretty much like, it's pretty much in the, horizontal plane in terms of like up and down, or maybe even a little bit up sometimes, but yeah, and you want that one, it's usually around 10. That is
It's
a
a long-
definitely no more than 10, but like you can
It's
do
9, 10.
Yeah, 9 or 10.
But you pop into the ventricle like 5.
Yeah.
It's a lot of soft
That's
pulsing.
Yeah. Yeah, and
the,
and the times when you might want to do that might be, if for some reason you can't, there's just no trajectory from the right, in the frontal ones, contusions or something else or some other reason.
or if there's like a giant
Yeah, yeah,
you'll want to avoid a
Yeah.
frontal.
Oh,
I've done that a couple of times.
Okay.
Where there's a massive ruptured ACOM or like a partly thrombosed ACOM, and you know that placing a Coker's point is significant risk of going through that, and you'll just do it for sure.
and sometimes, particularly, and the other time we'll do it often is if you've got navigation in the OR for like a tumor, posterior fossa tumor or something like that, and then it's just nicer because you can have the patient positioned prone for your case and just do the EVD at the same time after you're
Yeah.
prepped and draped and do it rather than having to do it first and flipping the patient, stuff like
Do it
that.
for like a
But-
stop with the
but yeah.
depression. We've done that.
Yeah,
Because it
I usually will do
this
this.
step.
Yeah.
Cool.
So, but it's nice to, if you're going to be doing an occipital one, it's nice to have navigation because it's much easier to miss than regular EVD usually. So,
In which,
I mean, we do it for shunts, so obviously a lot. So,
in which situations would you be going left frontal instead of right frontal?
I mean, if the left is the one that's entrapped,
Or if you have, for example, a big ICH or bleed that is gonna be in your trajectory from the right side, you wanna try to avoid going through that.
Yeah.
yeah.
or maybe the right lateral ventricle is just too casted, to put a catheter in where you think it's just not going to be functional.
But yeah, so generally we try to avoid the left side, right, which is more eloquent.
Yeah.
So to speak.
And in trauma, sometimes, again, still try to do it from the right side if possible. And, sometimes you don't want to put it on the side that everything's being pushed towards because you might accentuate that shift more, but sometimes you have no choice. Like there's just no way that that the contralateral side is sometimes more, it's easier to get your catheter in than the lateral side.
Hemicrania we did on Friday.
Yeah.
The reason that we did a left frontal EVD with the right hemicrania is because all that brain, there was a huge contusion of super friable. And we didn't want to put it through a ton of friable parenchyma, so we just put an EVD on the left.
Yeah. The other time might be too is if, say somebody had a right-sided injury and you're like, I think this patient might end up needing a hemicraniectomy, but I'm going to do an EVD first or maybe an ICP monitor, and you don't want to then have to replace them.
Yeah.
Then you might do it on the opposite side too.
That's fair too, yeah.
So sometimes that factors into it too.
I do that with bolts as well. I try to not put it exactly at Coker so that we have room for an EVD if we need it. So all that kind of like anticipation is important.
Anybody know like the main risks of placing an EVD? Like what are the negative consequences of doing an EVD? There's two big ones. And there's other ones that pass on.
Malposition.
Yeah. So definitely malpositioning is on there. Whether or not that's, you can count it as a complication, obviously, because it ideally doesn't happen. But that being said, like if you actually, depends upon what you consider a malposition, right? So when we actually document malposition, we document malposition that requires a replacement or it results in a non-functional EV. Usually those are kind of one and the same because, but if there's different grading scales that you can use to document, how good the placement is, and like, an ideal placement again is like you said, is like the tip at the foramen Monroe, or maybe slightly in the third ventricle. But then there's other less suboptimal ones, like, potentially having it going across the septum pellucidum and then the contralateral front horn, where it still works. It's just not necessarily as good. I mean, there's times when you might actually want that, if you want those two to communicate, if you have IVH and whatnot. So that's one. But hemorrhage, obviously, and tract hemorrhage is another, and then infection is the other. And those numbers vary wildly when you look at different literature, depending upon whether or not, for instance, hemorrhage, like, are they getting a scan right after the EVD on every single patient? Are they counting every like any corpuscle of like blood that they can see, or are they talking about only over a certain volume, like only like over 5 milliliters? So like when we count it for our QA, we count it as like, we count anything over like 5 cc's as like a clinically significant, because like if you start actually look and like document and are truthful about it, there's a lot of like 1 cc hemorrhage. Is not that rare. And like in the literature, it's like anywhere up to like 20% sometimes, or even higher sometimes. Yeah,
There's a lot of
depending
that
upon
also
depending on how we're
skin
just.
too, right? It
It can happen from skin. It can happen from the dura. It can happen from, patients are on antiplatelets or whatnot, things like that. What was interesting is like when we looked at the large bore catheters at Columbia, we actually found that there was a slightly less rate of tract hemorrhage, and one of the thoughts was just like the larger size was like tamponading it a little bit more. So yeah, but yeah, clinically significant ones are significantly less, and like, but like still single digits, definitely more than intraparenchymal ICP monitors have a much lower rate of hemorrhage and a much lower rate of infection. The infection for like intraparenchymal, like fiber optic monitors, basically zero. But with EVDs, obviously, again, it varies wildly depending upon the the series that you're talking about. But in a lot of places, it's around 1 to 2% to maybe 2 to 3% higher. Ours is particularly low here.
Speaking of bleeds and complications, I think something that's important that has come up for us recently is that when we're placing the EVD, we want to keep the systolic strictly under 140, especially those patients who come with ruptured aneurysms, no subarach, and we're doing a procedure that involves cutting the skin and drilling, and that can really elevate the blood pressure. So when we're doing it in the ED, we tell them we want it under 140, but then a minute passes by and suddenly look at the monitor and it's 180. And it's hard for us to keep track because we're drilling and doing everything. So I've been telling the PAs that stick with me during the EVDs recently, like keep an eye on that, call it out, because if this person re-ruptures while we're doing an EVD, then it's, almost futile at that point. So
I mean, any of those patients, I mean, where, ruptured aneurysm, ICH, you really just should have like a knee-jerk order for clovetapine order, right? Like these are our blood pressure parameters, and then have them order a clovetapine, or put in a clovetapine order with those parameters, even if they're 120, because if they go up to 150, you don't want it to take 15 minutes, to get it.
It's just a matter of,
yeah,
like,
and actually, exactly, yeah.
As long as patients put an A line in, like,
Yeah.
instinctively.
Yeah.
So
Yeah.
they're like cycling the cup every couple minutes,
Yeah,
and
yeah.
then titrating
Yeah.
appropriately.
And that's also where, like, my rule of thumb is that, anybody that's getting a monitor in the head needs an A line.
Yeah.
I mean, one, because that's just a more accurate way to calculate CPP from an arterial map if you can. But two, so you have second to second monitoring, because that those first 24, 48 hours are like the most critical, right? There's no real reason to not have it in arterial line unless it's just technically not feasible placement, which is a very small minority of patients. And there's other things you can do in that situation too. You can do a brachial one, you can do a femoral one. There's other places to put it, but really, if you're going to be sticking a catheter or a monitor in the brain, then you can stick a monitor in the radial artery. And likewise, the other thing, as a resident, I kind of, there's, how there's some patients where you're kind of like, oh, this is like, like great examples, like a Hunt has 3 with like kind of early hydro, like, maybe they don't need to be intubated, and, as soon as we get the EVD and they're going to wake up and everything like that. I just like, eventually, after having a couple of patients where like, they're disinhibited and trying and like contaminating anything, just like, just intubate them, have them sedated, totally everything under control, so that like the EVD goes as smoothly as possible. Steps is one where I think, it's a quick enough and easy enough procedure, that you don't have to have like you're not aiming for something the size of a pea from 10 millimeters away, basically. That you can do it without intubating, and obviously not intubating the patient is one of the benefits of SEPs, is to avoid it. But like for EVD, it's just, it's a lot. It's pretty much the hardest bedside procedure we do, right? In terms of like technical difficulty.
Separate conversation, but we're still having some issues with attending willingness to do conscious sedation for SEPs in the SICU.
Mhm.
I know that was a big issue my intern year, but
Yeah, I just spoke
still-
to Dr. Body about that, and there's supposed to be no issue with
I
that.
know, just some of the tanks are like resisting or saying, no, I'm not gonna do it.
Yeah, just let me know. And those,
One guy from last week, Sagana
Yeah.
had to intubate him,
Mhm.
because she refused to do it under.
Yeah, and the nurses also said if a patient's not ANO ×3, they can't undergo conscious sedation.
Not true.
I've never heard that.
not sure.
They make up all these things, I'm like,
Yeah,
that's not,
yeah.
that's not.
Yeah, let me know when those issues arise,
Yeah.
because in real time, because then, or, the next morning, and send me the MRNs, because then I can actually go to Dr.
Yeah.
Body with data and be like, these are the cases where, we should look and see, because the goal is to not have to intubate those patients.
As if we have to, damn, we should go to the OR.
Yeah, it defeats the purpose.
Yeah, and I've had the flip side where in the ED, they won't intubate the patient.
Yeah.
And I'm like, this is an emergent
Yeah.
procedure. And they're like, well, give us an hour.
Yeah.
And so I just start setting up, and the second the patient's desatting, I bring them over and they finally intubate. But it added like 10, 15 critical minutes where I could have been placing a catheter. Anyway,
Okay, yeah, so we can go back now to what do we do when we receive a patient, or when we go to the bedside for the first time to assess a patient who had an EVD place. What do we wanna check?
We want to check for the positioning, making sure zero to the tragus, also that it's at the desired level that you want,
Yeah, so we wanna first of all,
and make sure it's open.
Yeah.
A lot of times you don't miss close.
exactly. So we wanna make sure first of all, like, what was the exam of the patient?
Yeah.
And we have to reassess that's the exam that we've been told, and also make sure ourselves that we have the same neurological exam. Then we have to check how is the head of the bed, and what was the desired position, and that will check that the head of the bed is at that position. Then we have to check the ICP. And also we have to, as you said, make sure that the EVD now is open, that the EVD is properly zero, that at the proper level, and also at which level do we want the EVD, and if we want to have like the EVD continually open and just close to measure the ICP, because as we all know, the EVD can just do one thing at a time, right? We cannot measure the ICP while the EVD is training. So most of the times we will keep the EVD open at all times, unless we want to measure the ICP. But sometimes some attendings or in certain conditions, we want to just train a certain amount of cc's per hour, right? And then one other thing that we want to check on the first initial assessment, but also every time we go to the patient's bedside to do even a neurological exam, is to check the appearance of the CSF, right? Is the CSF bloody? It is purulent in the cases that the EVD was placed because the patient has ventriculitis or a CNS infection. I want to see how that CSF is progressing, right? Like if you see that the CSF was kind of tinted, like a bit bloody, but not too bloody, and then you go to the bedside and you see that the EVD is clearly more bloody, you wanted to notify the provider, and because maybe, there was in case of an aneurysm, maybe a rupture, and maybe an increase of the intraventricular blood, right? And then the other thing that we have to make sure is that we keep a close eye on the.
Good morning. I'm sorry to interrupt. You guys know when you're gonna be finished, but the IT's here. They have to put their address on the screen.
15 minutes. In 15 minutes.
15 minutes?
Thank you.
Thank you.
And then the next thing that we can go through is like, how do you zero the EVD? That usually should be done ideally every change of shift, like 3 times per day at least, or every time the patient goes for like leaves the room for a scan or something like that, or something happens, has a seizure or anything happens, the patient moves, then we'll have to zero it again, right?
Yeah.
How do we do that?
So first, I just want to say, so yeah, when, if somebody calls you about an issue with the EVD and it's not draining or whatever, yeah, the first thing is just to double check the system and make sure everything's set up the way it's supposed to be set up. Like you said, make sure everything's open. Make sure, sometimes they'll be, be clamped in one spot, either here or over here. What I always like to do, so assuming that everything is set up, it's at the height that I want it, then I take the EVD and I lower the EVD manually, I take it off the pole and I lower it, or I just drop it down to -5, but sometimes I just need to lower it. And if it's patent and draining, it should drain, when the level of the top of the Piritrol is at the ear. I mean, it shouldn't really need to go much below that. Sometimes if somebody has really low pressure hydrocephalus, you might need to. Back in the day, before we had this little thing, so this is a filter, so that prevents the CFF from going back out of the Piritrol backflowing into the intracranial space and into the CSF space. And it's mainly there to prevent infection. So that's one way that it was thought that people could get ventriculitis, is if the CSF is flowing backwards at any time. And so that prevents that. So you can't raise it up and see the CSF going backwards. But back in the day before we had that, that would be one way to test it, would be what's called titling, where you drop it down, you should see the CSF flowing forwards, and then you put it up in the CSF so it flow back. But that filter will prevent it from flowing back. You can still see it flow back if it's not as far, if it's not beyond the filter though. And then then the next, and then during, say it's still not flowing, then I'll look to see if there's some obvious reason. Is there like a big air bubble that's maybe airlocking it, or a piece of tissue or blood clot somewhere that's obvious. But then kind of go from there.
Yeah, so we can, we can finish off how first before zeroing how to troubleshoot the EVD that it isn't working, right? And one of the things that we also have to check is the dressing, right? Because sometimes it may be oozing around the dressing, or maybe the patient went to the scan and accidentally it was pulled out. So just always make sure that even without, you don't need to undress the incision or anything, but just make sure that everything is not soaking and everything looks good in the proximal end of the EVD, right? And then if you, if the EVD isn't working, and you follow the EVD, okay, proximal, it looks like it's okay. Nothing is soaked. Everything is open as it should be. What do you do next?
So after I've inspected the tubing itself, and then I try dropping it, seeing if it's draining, if it's draining very slowly or not draining at all. Assuming that it's not draining at all, then the next thing I want to do is to get a sterile syringe and flush. So we always start by flushing distally. Sometimes it can be airlocked and all this tubing, like we said at the start. So you're connected to the patient's head on this end. We turn this clamp so that it's away from the patient, or so that you can't push any fluid down into the brain. And then you connect through your port here, and you can flush all of this distally. Then after I do that, I reopen to the patient, I drop again, I see if that's fixed it. Hopefully it has. If it hasn't, then probably your occlusion is proximal. So if that's the case, then you can do the inverse, where you would then close off distally, attach your syringe, and give a very, very small but quick push of like 1 to 2 cc's to hopefully flush whatever is clogged in here, plugging up these little holes at the tip. And then same thing, you stop, you open, you see if it drains, and hopefully that does it. I know some people like to pull back when they're doing this as well. They'll like push in and pull back. I've not done that.
I do it, but I kind of like do I wouldn't recommend it to everyone, but if I do it, it is very gentle, just to see if I feel some resistance. And when I feel some resistance, I know that it's clogged. But I wouldn't try to suction whatever is in there. I would just do it to kind of feel what is going on. But yeah, it's not routine done. And I would say if you want to do that, just do it very, 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 very gentle.
Right.
You feel any resistance at all, not keep, because you can make the thing actually worse. If the whole tip is not inside the AVD, these last holes, you can be actually suctioning brain and make the obstruction even worse, right?
Yeah, and obviously one of the things that clogs it often is the choroid, and you don't want to like suck more choroid in or like cause it to bleed or whatnot. Usually if you flush it, that's hopefully going to fix it. The one time that it wouldn't be was if you do have like a piece of tissue that's in your catheter, nowhere near the holes it's clogging it. That's where maybe aspirating it is going to be the thing that fix it. But again, only do it if like you're not getting that much resistance and it is like you are getting some fluid, like stuff is coming, and usually in that case, you'll be able to see it, what it is, relatively soon, hopefully. The other thing I always say is, like, use the kind of smallest syringe that makes, like, I wouldn't use anything over like whatever, 10 or 12 cc, but sometimes even the smaller ones are better because they don't have quite as much pressure pull on it. So, yeah, but yeah, definitely always want to be careful with aspirating. And then the nurses have a setup here, which is probably one of the reasons why we do have a lower infection rate, where they use a pressure bag to help with the distal flushing so that you can actually do it without opening the system at all. Which, and it flushes backwards through the transducer and then out distally.
And then obviously always sterilely prep this. I prep it before and after just to be safe.
Yeah, that's good idea.
Okay. So yeah, how do you zero the
That's fine.
then? Yeah, you can. How did you open the cork and bring out the thing to the Travis? Like you have to re-zero the
So yeah, positioning is important. So you want the bottom of this to be lined up with the patient's tragus. So the 0 line here is basically you want it with the patient's tragus here. And then something you'll notice is as you've set this all up nicely and got it leveled, and then someone just goes and presses the bed and moves the head. So usually, I think you were talking to this about this last time. There's beds that have the pole that moves with the head, so that you shouldn't have to adjust that. We don't have those, unfortunately. So yeah, once that's leveled up, then you can open this so it's open to the pressure monitor. So it'll be like that. And then you can press on the screen ICP 0. I think the pressure bag has to be closed when you do that. Is that right? When you're zeroing?
Once you zero, you'll have to reopen because it has to calibrate.
And then it has to recalibrate.
Right, it zeros with the atmosphere, like a regular zeroing A line. It's the same transducer as an A line. And then once you're zeroed, you can put it back to.
Yeah, so there's two ways you can, what we don't have on this right now is the transducer, right? So it's an A-line transducer, so there's like a line of cable and then the transducer. There's different places you can attach it, right? So some places they'll take off that extra cable, or sometimes even leave it on and attach it here to this one. Sometimes they can, and then you can also attach it to that one. I don't particularly like it on that one because then if you need to aspirate or flush anything proximally, you can't use that port, right? You have to use the other thing, but you could theoretically do it off there. So the things you need to have in line at any one time when is like the 0, the red 0, and then the transducer needs to be in line with that 0, and those both need to be in line with the external, the EAM or the tragus, whichever you're using as a 0 point. And then basically you're opening the transducer to air. So the transducer, you're shutting off the rest of the system to it, to the patient. So you're not letting CSF like just pouring out. But then opening the transducer to air and just telling the transducer that this is what 0 atmospheric pressure is, right? And then hit the 0, and then once you see once it comes up 0 and it's the flat line is 0, then you put the cap back on and then close off the transducer to the air and then open it up to the patient. Yeah, and so I always, I pretty much always do that every time around just to make sure it's like the number I'm getting is like accurate, but it should obviously happen anytime that the patient's head is adjusted, things like that. You have to make sure that everything is maintained lined up. Yeah, so it's nicer if they have a bed where they're able to, it's able to move. Theoretically, right? You should really only need to do it if you're disconnecting the cable between in front of the monitor, or there's some major change in like atmospheric pressure the patient's been doing, things like that.
A lot of times they have
Yeah.
negative ICP.
Yeah.
And then I don't think the nurses call us for that, because they're like, great, it's not too high, but it's like a negative ICP shouldn't be.
Yeah, I mean, there are times when you can have a negative ICP, but in most cases, if you have a negative ICP, it should tip you off that, to just double check everything and make sure everything is actually working okay, and then the bedside monitor is calibrated correctly. Because, right, like you can technically tell the ICP on somebody from an EVD without having the number and without having a transducer, right? So
Move up,
yeah,
down,
if so,
drop
yeah,
this.
so if you drop, say the water column, right? This is just a water column, right? So say it's like here at 15, right? And then I drop it down and it flows forward, and then I lift it up, and it, it goes down from 15. I mean, your pressure is somewhere around 15, basically. So yeah. So it's just a water column, just like a manometer is essentially. So all the fiber optic transducer is doing is taking that pressure in that water column and transducing it into an electrical signal that gives you like the number on the machine.
And then for all these, including the IR flows, we're always doing millimeters,
Or
we're doing centimeters.
You always use, the convention is, and I don't know why this convention went this way, but it's the height of the bag is always centimeters of water, and the pressure though that we deal with is millimeters of mercury. Which is, when we do an LP, what we're doing is centimeters of water, right? We don't usually use millimeters of mercury, but I don't know why the convention ended up that way. I think probably it ended up that way just because centimeters of water makes more sense when you're talking about like a water column and dealing with the pressures of that, but then, everything else ended up being mercury in terms of like intracranial pressure.
I mean, if you want to calculate the CPP or something like that, it makes sense that it's millimeter.
Yeah, no, exactly. So that's why I think they ended up with two
Because you
different.
cannot subtract centimeters of water to the millimeters of the blood. Yeah.
But when they started doing that, they didn't then convert, the bag heights and doing LPs to like using millimeters of mercury, even though they could have.
And so what the two numbers from there, there's two things that you want to look at for ICP. One is the number, right? Like, and the other one is the waveform, right?
The waveform, yeah.
And
Oh, sorry. I was just gonna say that brings up a good point though, right? Like, I mean, 20 is about as high as we will ever put it, right? But you can see then, like, basically they should drain even at like if their pressure is 15 millimeters of mercury, it would still technically drain because that's the same height in the water column, right? So if you stick the bag to 20, anytime the pressure is over 15, it should really still be draining. So
okay, and so what's the usual waveform? How does it look like? I copy pasted from the internet. So the normal waveform, it looks like this, right? You wanna explain it? It has three components.
Voice question, like every year, there's voice question.
And this one has like a small label there, so it's easier.
I don't think I had a board's question on it, but there's
Always
always.
a very classic question, what each wave means.
So yeah, you hope to have 3 peaks to your waveform. P1, P2, P3. Yeah. So P1 comes from your arterial pulse. P2, we usually use it to assess compliance. And then P3 it's kind of like the
Venous
I
component.
was gonna say diastolic.
Yeah.
But yeah, something like
Yeah.
that. It's similar to that.
yeah, I mean it matches up right with the arterial waveform, basically, at least P1 and P3 do, right? So
And you have this, the usual waveform that we usually look at is correlated, as we just said, to the cardiac system, right? Arterial compliance, like how the brain is doing, right? With that increase or decrease of pressure, and the venous one. And then there's another different waveform that is called the V2 that is related to the respiratory system, right? So you have these small ones that are related to the cardiac system, and then with the respiratory pattern, it will change as well and go up and down. And then these are like, so the way it looks is always like the P1 should be the higher one, and then it will go progressively down, right? If you see that the P2 is bigger, higher than the P1, or even they at the very end of this stage, they kind of fuse together. What does that mean? If you have a P2 that is a higher than
Higher.
P1, or even they kind of become one.
They have poor compliance.
You have you first that you have poor compliance, right? That means that the brain is not able to adjust to that increased pressure.
So you could have, there's different reasons, but like obviously cerebral edema would cause poor compliance. Blood in the brain or a mass lesion in the brain that's already exerting mass effect would cause decreased compliance. Hydrocephalus can cause decreased compliance because the ventricles are already expanded kind of to their maximum capacity and have no more ability to accommodate additional CSF. So often you'll see, I mean, you might see the poor compliance with somebody with the normal ICP, but that's somebody that you would be more concerned about than somebody that has like the normal waveform. And then obviously the other times when you'll see it is, somebody that has like borderline high or high ICP, and realistically, like on the waveform, the way it looks is it kind of starts to look like a triangle.
Yeah.
As opposed to like going up and then coming down. It's like, starts to look more like triangular. That's a bad sign. That's somebody that's like any additional increase in volume of anything in the brain, whether it's CSF, blood, or edema, or whatever, is going to cause like a very large increase in their ICP.
So what do
Yeah.
you do when you have an EVD that's draining, working fine, transducing ICPs, but the waveform isn't showing up well on the monitor?
Depends why. So in somebody that has a decompressive craniectomy, they may actually have a very poor waveform because their compliance is very high.
Right.
You've actually done a very good job of decompressing them, and there's just not. And one of the things we can do is you can do it like we would call it, like kind of like flapology, but you could just very gently put your hand over the flap and put a little bit of pressure, not a lot, just like a little bit, and you can see like the waveform will go up, increase. So the pressure is being transduced correctly. And sometimes what you'll see in the same patient is they might start off like that, and then as they edema evolves or it gets worse or what have you, you may actually see the waveform more clearly because their compliance is decreasing enough to like actually see the waveform now. But you can imagine, right? If you have like a balloon that's just like kind of like a floppy balloon, it's going to be very hard to get like any sort of like waveform pressure reading in that. So that's one reason. Another reason, we'll often see it more often as if like the drain isn't working properly and isn't draining or is non-functional, then you might have a poor waveform, and those two kind of combine really means that like the readings from that EVD are unreliable at that point. Yeah, I think those are
Yeah, I don't know what else.
for the main thing. You could get it. So the waveform, when you talk about like ICP waveform analysis, oftentimes they're talking about this, but then there's like you can get even more involved in it because there's like different waves of ICP and TBI. There's like B waves and all these other waves of like basically these periods where like the ICP in a patient will just kind of go up, and they all have to do with like different states of like autoregulation and things like that. But like some of them happen like slowly over like hours, basically, where like the ICP goes up, stays up, and then will slowly go down. And then there's respiratory variations on top of that and things like that. So, if some people get really into like involved into like analyzing those to like kind of like prognosticate and things like that. But, all right, I think that's good. Any other questions?
Maybe another time we could go over like removing EVDs, because like for now I do them, but in case it's just yeah, just in case I'm ever not around and then someone else has to, a PA has to pull it out, the steps and
But you can actually just
for all the intracranial drains, it's important to have head a bit flat because then we don't want to introduce air. And then also some of that pressure helps kind of tampen up against that you're creating when you pull this. Something I like to have ready is a wet piece of gauze, because then right when you pull the catheter out, you can plug that up while you grab your stitch and everything. It's that time in between pulling it out, grabbing stuff, you can introduce a lot of air. And then closure, just a hemostatic stitch, like a figure of 8, making sure it's really nice and closed. I think what Alex has taught me is even when it's closed, it may appear like it's fine, but then sometimes you may have CSF that leaks through that hole, so we'll put now dry gauze on top and a Tegaderm. And just check that the very next day and see if that started to like soak through, get collected with CSF, and you know, we might need another stitch.
Yeah, I used,
Thing with these, I'm sorry,
Yeah.
it's just always make sure it's full thickness, right? Don't just go through the skin. Make sure you're really going like almost down to like the periosteum with these. I usually don't like to do a simple interrupted, like at least a figure eight, or you can do 2 stitches. Something to really
Figure eight.
those.
What do you
I
do
like
for-
figure eight.
yeah, I used to do figure eight, and I used to actually, what I would do is I would place my stitch before taking it out.
Oh,
So I would put it in and have my stitch ready to go, so all I need to do is pull it and then tie it. Basically.
So,
So you have to make sure that you don't hit the, you know,
Yeah.
stab the EVD, but you can put in the back part and you have it basically ready so that you can just pull it out.
No, sorry,
And then,
I love that.
tie around it. And then, yeah, I mean, I used to put like a little piece of like Xeroform too on it if you have it. That's not really necessary, but yeah.
Do you like to have
Okay,
it open to drain while you're doing it? Now, since it's like off suction, like I just try to reduce any
I always had it, you
You
want
should
to
always close it.
close.
Yeah, yeah. Close it, you know, if it's like some other drain, like a JP drain, or you obviously want to off
Take it off
suction,
suction,
yeah,
off suction.
yeah.
You don't want to track it.
You want it, yeah, you want it to be as like loose as possible.
So I thought if this is closed and then you pull back, then you're creating negative pressure.
It's closed, not gonna drain anything.
So yeah, basically make sure you have everything you need before you start.
Like, I see what you mean, like in theory, maybe if you irrigated through it while pulling it, it would be the best thing, you know, it would smooth it out and it would like lubricate it.
Right, the air from
But-
coming.
but yeah, no,
and
just
then it is
Have it
coming
closed.
down. In a regular ED, you can just go as deep as you can. That's fine. You can even hit the bone with the needle. It's nothing's gonna happen. Once we do the EVDs in the OR for migraines and the EVDs coming out through a place that may or may not have bone, still try to go deep, but don't. You know, there's not gonna be bone there, so don't go all the full thickness of the needle down, just in case. Be mindful that there may be no bone there. Right?
Yeah, that being said, usually when we do a hemicranium, we're tunneling it out, the tunnel
Yeah,
at the site should be
it's-
over bone, so.
Yeah, but in
Yeah,
case, yeah.
yeah.
I don't know, like,
exactly.
I don't,
I think everything we described also applies to other intracranial drains. So if there's
Yeah,
Yeah,
yeah.
like a subdural. catheter.
Yeah, and just kind of going back to like the leaking thing, like leaking is never normal nor okay. Because obviously leaking CSF is just like you're guaranteed to get an infection if it's not treated relatively soon. So if you have an EVD in place and it's leaking, it's also an indication that there might be a problem with the EVD, right? Like it shouldn't really be leaking around it if the EVD is working fine, because the EVD should be the path of least resistance. And even if there was like not a full watertight closure, it should really be coming through the EVD and not around the EVD.
Mm.
So sometimes you won't see it leaking until we try like clamp trial, and that's because there might be, might need to be sewn again. But if we're not in the clamp trial, you know, it's maybe a sign the EVD is not working. But in either case, it needs to be addressed in some fashion. And similarly, once you've taken it out, if it's leaking CSF, we have that's an indication we have to put in usually another stitch or something like that.
That is something we had to troubleshoot when we were starting to do half of Mount Sinai, is the
Yeah.
exit site is much bigger
Mhm.
than this exit site.
Yeah, because
And so we often have to put 2 drain stitches in.
Mhm.
So just in terms of the workflow,
Mhm.
we do like 2 U stitches.
Mhm.
One kind of closer to the exit site, one a little further. Just because we noticed a lot of the air flows were leaking around the catheter, just because that exit site was pretty big.
Mhm.
So we'll figure that out with
Yeah.
during our flow. Something to know.
it was a shame we didn't have them last week, but we didn't have place at least one.
oh,
Twice.
so yeah, there's
The one that we did the bilateral and the one,
Yeah.
the lady that's already Castillo.
There'll be more.
They
they're
will,
coming. Yeah,
They're going.
they've really been
Yeah.
giving us
All right.
trouble.
Very good. Thanks, everyone. Thanks, Dr. Salgado.
You guys see how we beat some Lincoln?
All right.
Cool.
So you guys are
That's-
pros.
Perfect.
Anything you do technically different?